So we have three outstanding speakers this morning. Our first speaker is going to be Dr. Mike McGuire. And really, we don't need an introduction for Dr. McGuire. He's very well known, but I would like to highlight a few of the important things. He did his training, both his dental degree and his perio training at Emory. I think it was tough for him to get away from Texas for a few years there, so he started out in Houston and ended in Houston. He has a private practice and does amazing things for Texas. Houston is lucky to have him. He is a diplomat. He's also a director of the American Board of Periodontology. He is a past president of the AAP. He's won numerous AAP awards, including in 2007, the Master Clinician Award, in 2006, the Earl Robinson Regeneration Award, and there's 2 times that he has received that particular award. 2004, the Presidential Award, and I could go on. He's well published, over 50 articles, chapters. He's lectured locally, internationally, and I think we all know that he's going to give us a fantastic presentation this morning. So, Mike.
Thank you, Dr. McAllister, and thank you, everyone. It's always an honor and a pleasure to have the opportunity to present at the AAP. The topic of my presentation this morning is practical applications of growth factors and cell-based therapies. You know, if you have attended any of the lectures at all during this Congress, you know that in a very predictable way, through traditional periodontal plastic surgery, we can increase keratinized tissue, we can cover denuded root surfaces. With less predictability, we can augment papilla, and rarely we can achieve regeneration. I'd like to share with you projects that we're accomplishing at our center utilizing tissue engineering to accomplish all of these objectives, but to accomplish them without a donor site, with reduced morbidity, and with an unlimited amount of donor material, with increased predictability, more robust results, and a more natural outcome. It's important that I disclose that the following companies have funded the research you're about to see: Organogenesis, Isologen, OsteoHealth, and Geistlich Pharma, but I always maintain complete control of reporting of data and content of my lectures. You know, tissue engineering brings together the power of modern physical, chemical, and biologic sciences, and it represents a spectrum of novel approaches to achieve regeneration. I like to think of tissue engineering as a broad matrix. In the center of this matrix, we have biologically based devices. These are biocompatible substrates that either through physical or chemical signals can direct cellular growth. On the other end of the tissue engineering matrix, we have bioactive molecular-based devices. Here the theory is that if you and I can identify the appropriate biologically active molecule, if we can deliver it to the site at the appropriate concentration, for the appropriate time, that these molecules then cause cells from the periphery of the defect to migrate in, to differentiate, to proliferate, and finally to participate in the regenerative process. On the opposite end of the tissue engineering matrix, we have live cell-based devices. These devices bring with them cells, cytokines, collagens, all sorts of things that we need for regeneration. And I'd like to share with you studies that we've done recently using all 3 areas of the tissue engineering matrix. Let's begin with the center, the biologically based devices. I have a little confession here. I've kind of avoided this area over the past, and I've avoided it because I thought it was the boring part of tissue engineering. You know, to me, in the past, I thought of biologically based devices as these inert scaffolds that don't really do too much, or these membranes that just kind of sit there, maybe guide a little cellular growth. And in fact, you know, they only carry the exciting stuff. They carry the bioactive molecules, they carry the cells, and it seems that many of them actually get in the way of regeneration. I'm now finding that's not necessarily true if you choose the right membrane. In fact, if we look at the state of the art as stated by Stephen Babalak, he's one of the really leaders in tissue engineering scaffolding. He states that biologic scaffolds composed of extracellular matrix have been shown to markedly affect angiogenesis, cell proliferation, migration, differentiation through cell signaling mechanisms. These scaffolds have been shown to be rich in growth factors and various types of collagen. And more recently, degradation products of the parent ECM molecules have been shown to have significant biological activities themselves. From this perspective, perspective, degradable biological scaffolds may be considered control-release devices for a variety of functional molecules. So today, if you pick the right scaffold, it's not your dad's old Oldsmobile. You know, there are lots of these membranes and scaffolds that really don't add much to the mix, but there are some that can really move the entire process toward, from repair toward regeneration. And the one we've been doing research on over the last few years is a xenogenic collagen matrix. When you look at it, you immediately see there's something very different about this matrix than the ones you're typically using. You see that it has two layers. It has a cell-occlusive outer layer. It's got a soft, spongy inner layer. It's made of porcine collagens 1 and 3. And if you look at a high-power photograph of it, you can clearly see the two distinct areas. It has this protective, reinforcing area of collagen 1 fibers, and then it has this inner layer of both intact and fragmented collagen fibers. And I'll get back to in just a moment the importance of the fragmented collagen fibers. But it's really the marrying of these two, the reinforcing matrix and the cell signaling source for regenerative wound healing, that's important. Because when you look at this initially, you're really looking at the macrostructure, and you're thinking that's the unique part. And it is unique. It's much thicker, and it does stabilize the cells. But it's the microstructure that makes it unique, because the body recognizes collagen 1 as normal. But this inner layer that has both the fragmented and the intact collagen fibers, with the fragmented collagen fibers, what happens, it allows the collagen helixes to unwind. And as these collagen helix unwind, they expose what would be hidden or cryptid amino acid sequences, such as RDG and other sequences that we know are important for regeneration. To give you an example of how we've been using this is an interesting example just to show how it works in an exposed environment and how impressed I was with wound healing on this. I was waiting with this patient. We had done an implant posteriorly here. We're waiting on that to integrate, and she said, you know, Mike, I don't like this pigmentation that's between my teeth, and she said, can you do something about that? And typically I would manage this with a graft from the palate, and you could do that, but it's going to be challenging because it goes into the papillary region. Also, there's pigmentation right at the free gingival margin. So, you know, I'm concerned about recession and all those kind of things. And if I'm taking tissue from the palate, while I might be able to do a tissue replacement graft, likely I'm going to see soft tissue changes as far as color and texture. So I remove the pigmentation. I just use it as a pattern on the matrix, and I suture it to the boundary of the matrix. And I draw your attention to wound healing at 1 week. Look how little inflammation there is at 1 week and how it appears we're maintaining tissue volume. Here we are at 4 weeks, and at a smile at 4 weeks, very rapid healing, and we're not seeing the borders that I would see as far as if I were using connective tissue grafts. So the material is unique in that it works in an exposed environment, an open environment, and then we did our RCT with it under a flap. And we compared it with the connective tissue graft, which is, of course, the gold standard for root coverage, and we placed a chronally advanced flap over the material. It's a 25-patient study. We looked at it initially at 6 months, then at 12 months, and we're now looking at 24-month data. This was published, if you have an interest to really get into it, a couple of months ago in Journal of Periodontology. Our primary efficacy parameter was recession depth, and we looked at a whole host of secondary efficacy parameters. Just to give you a feel for the type of surgery we did, you had to have at least 3 millimeters of recession to get into the study. We marked the CEJ just for photographic purposes so it's easy to see. Partial thickness flap, intraoperative measurements. I am suturing the matrix to the papilla here, chronally advance the flap, and at 1 year we have 100% root coverage, a nice aesthetic result. So when we looked at our data at 1 year, we found there were only 2 parameters that there was any statistically significant difference, and that was recession depth and percent root coverage. And of course, that's the same data, it's just a different way of expressing it. So when we looked at connective tissue graft versus our chronally advanced flap with the matrix, these were the only 2 variables that had any statistical differences. And what we found was that our connective tissue graft, we achieved 99% root coverage. And if we look at the xenogenic collagen matrix, we achieved 88.5% root coverage. And a surprise with this was that we actually generated more keratinized tissue with this matrix than we did connective tissue. Unless I'm mistaken, I think this is the only RCT in which Connective tissue graft is the control where the test actually generated more keratinized tissue than did the connective tissue graft itself. So our conclusions with this is that we're getting the percent root coverage, and the percent of sites achieving 100% root coverage utilizing this material are in upper limits of expected range if you look at meta-analysis, systematic reviews. But we're doing that with less morbidity, less technique sensitive, and better aesthetics. It has certainly the potential to reduce under treatment, because if I'm doing connective tissues from the graft, from the palate, oftentimes I'm forced to only treat those areas in greatest need because of the limited amount of donor material. We have an increased amount of keratinized tissue over connective tissue graft. We're beginning a study to evaluate it, to look at increasing keratinized tissue around teeth, and it may be a good carrier for other agents. Again, as you look at lots of biologically active agents, oftentimes the scaffold is a problem, and we need to look more at release and binding kinetics, but it may be a good carrier for other agents. Well, let's move from the center here then over to the live cell end of the tissue engineering matrix. I think this is an exciting area. I think all these areas are exciting. It's a great time to be a periodontist. But living cells, these live cell-based devices bring with them lots more than just the cells. They're, of course, bringing with them cytokines. They're bringing with them collagen. They're bringing with them glycosaminoglycans. But theoretically, the most exciting thing that these live cell devices can do is they can deliver these products on demand. Because, what's one of the problems we have with biologically active molecules? We can identify one that we know is robust, but oftentimes we don't get the result we want. And why is that? Well, did it really get to where we wanted it to? Did it stay there long enough? Maybe it was there too long. Was it viable when it was there? These cells, they're living. They have little surface receptors on them, and they're talking to each other, and they're talking to the native environment. And theoretically, they have the potential then to titrate exactly the amount of cytokines and other things that are necessary to move toward regeneration. Now, anytime you and I are faced with an oral mucosal defect, we've got a couple different surgical strategies that we can use to manage that. Today, we usually look for a procedure that results in primary intention. We're going to mobilize the flap and we're going to suture it, or we're going to harvest a graft and close it with the graft. Or we may choose to choose a procedure that results in secondary intention. In periodontics, we used to do the pushback procedure. Today, procedures that result in secondary intention have kind of fallen out of favor because of the time that it takes, because of the morbidity, the inflammation. But the truth is, even with procedures with primary intention, you can get a scar as you mobilize the flap and suture it, or you may get a tissue mismatch with the graft. And no matter whether you're working with procedures that are revolving around primary intention or secondary intention, they both fall on a spectrum of wound healing. On one end, we've got a keloid, we've got a hypertrophic scar, maybe we have a tissue mismatch from the paddle tissue that we placed here. We know that kids heal faster than adults. We know that fetuses heal without a scar. And we know that certain animals, like newts and salamanders, will regenerate entire appendages through enhanced forms of secondary intention. So our job as scientists and as clinicians is to try to find procedures that will allow us to move from the scar end of the spectrum to the regenerative end of the spectrum. Arnold Kaplan is one of the tissue engineering gurus in mesenchymal stem cell research. And Dr. Kaplan really believes that all of us have a little bit of newt in us. And he reminds us that, for example, there's a number of these examples in the literature, but there's a report of a little kid in England. He was 3 years old. His finger was cut off in an accident, and he was in a remote area. He couldn't get to a hospital. All they could do was to keep that area clean and bandaged it, and he regenerated an entire digit. So while you and I may think of secondary intention as being the old, crude way of doing things, I want to remind you that if you look at any regenerative model, be it animal, neonatal, or fetal, they all operate on the level of enhanced secondary intention. And if you think, well, I'm going to help this old newt out here, and I'm going to put a suture in this limb bud, the limb bud doesn't grow back. You've got to leave this alone. So Dr. Kaplan believes that all of us have great potential for regeneration. We just need a little boost. With him, he's working with mesenchymal stem cells, and he creates a microenvironment for regeneration. The material that we're using to give the body a little bit of boost is a living cellular construct. Now, You have to kind of change the way you think about these things because this doesn't operate like a graft. Cells that come in from a graft, those cells stay there. They retain their phenotype. There's, of course, problems with a limitation of donor material. There's problems with morbidity. But one of the problems you don't think of is that there is certain evidence that if you close a defect prematurely with a graft, you can actually abrogate the body's innate ability to regenerate. So here the material is, here's the LCC that applied to this defect, and at 3 weeks you can see how it's beginning to heal. Now if we had put a skin graft here, you would always see the border of that skin graft. You may be able to get it to close, but I draw your attention to at 6 months, not only is this closed, but also you have return of natural pigmentation. And that's because it's not working as a graft, it's working through enhancing the healing through secondary intention, moving that down the spectrum of wound healing. We're doing the same thing in the oral environment. This is one of our patients from the pivotal trial. You can, I think, appreciate this is just mucosa here. We're not going to try to cover the root surface, just add in keratinized tissue. Now, I've created my bed. If we were just placing this material and it was going to act like a biologically active Band-Aid, then we would just get faster healing without a scar, but end up with the same tissue we started. But this material doesn't work like that. Here we've placed it on, and what it does is it actually changes the trajectory of healing. It allows us to end up with site-appropriate differentiation of the cells that belong there. So instead of having mucosal cells, we now have a nice functional band of keratinized tissue. These cells come from neonatal fibroblasts and neonatal keratinocytes, and they bring with them a whole host of cytokines. I've highlighted just the ones that we already know that are important in periodontal regeneration. BMPs, fibroblast growth factors, PDGF, TGF-beta1, VEGF. We know these are important. One of the difficulties we have is how do we get those? This material potentially will act as a reservoir for these cytokines that we know are important, and again, theoretically may be able to deliver those important growth factors on demand. Now this is in vitro gene expression, but you can see that certain of these cytokines are actually elevated, the production is elevated after application, and that's because it's interacting with the host. You need a little more of this, here it comes. You got enough? Okay, we'll shut that down. So theoretically, the potential here is very exciting. And of course it brings with it all the extracellular matrix components that are important as well. So we used this material in a study we published in Journal of Periodontology, a pilot paper that was published a couple of years ago where we were using the control as a free gingival graft. To be honest, the free gingival graft isn't a good control. You can't think of this as a graft. So a better control would have been a pushback, but you can't get that through an IRB. And if you look at what we achieved as far as keratinized tissue, yes, the free gingival graft generated about twice as much keratinized tissue, but we generated 2.5 millimeters of keratinized tissue without a donor site, which I think is pretty outstanding. And if you look at aesthetics, the LCC comes out far superior, much better color match, much better texture match, and that's again because it's not acting like a graft. It doesn't retain those palatal phenotypes. And with that positive information, we then rolled that into a large multi-center trial. We have 4 centers, our center in Houston, University of Texas San Antonio with Drs. Cochran and Melnick, Michigan with Dr. Gianobili and his group, and Mark Nevins in Boston in his office. It was a 96-patient pivotal trial, 6 months. Our primary efficacy parameter was to achieve greater than or equal to 2 millimeters of keratinized tissue, and you can see we had a host of secondary and tertiary endpoints. We elected both in the pilot and the pivotal trial to use 3 layers of this material. So it's a Z-fold, and the keratinocytes are on the outside, the fibroblasts are on the inside, and on the pilot study we also placed a 4th layer just to cover that and to act as a buffer from the copac that we placed over it. In the pivotal trial, we also quit standardizing the width of the LCC versus the free gingival graft because, again, it's not a graft, so it doesn't make sense to do that. So we basically tried to put as much of it as we could, basically whatever the vestibule would allow. So I think you can appreciate here just mucosa. Here's the LCC, the free gingival graft, and you see we're getting a very similar amount of keratinized tissue with both. And the last one I'll show you, again, purely mucosa, And yes, that's what we were all trained that a free gingival graft looks like. But I draw your attention to this. Nice functional zone of attached gingiva. You can't tell that I was ever in there. And I think that's where we're going today. With our techniques, we know that we can predictably generate keratinized tissue. We want to take it to the next step so that we can create tissue that's identical to what Mother Nature intended. And this type of surgery and this type of technique will allow us to do that. So in the pivotal trial, we moved with our techniques improved, and we moved from 2.5 millimeters of keratinized tissue in the pilot to a mean of 3.21 millimeters of keratinized tissue in the pivotal. And how much keratinized tissue do you need? I think that's probably enough. And again, our aesthetic outcomes highly in favor of both in color and texture because it's not a graft. So the conclusion of this was that LCC is effective and well tolerated in a non-submerged healing environment, both with the pilot and the pivotal. It generates more than 3 millimeters of keratinized tissue, provides improved aesthetics, greater patient preference, and no donor site morbidity. And this product is now with the FDA for evaluation. Before we leave the live cell end, I also want to briefly go over RCT we did a couple of years ago, utilizing the patient's cells to augment papillas. You know, this is the only area that traditional periodontal plastic surgery still is lacking about giving us something to be able to handle predictably. And to my knowledge, this is the only RCT where anybody's tried to augment papillas. Everything else are case series, which are case reports, which are important, but they don't really tell us much about predictability. So here we're taking a small sample of the patient's tissue from the palate. We're sending it to the laboratory. The laboratory breaks out the different cells. We're growing out the fibroblasts to 200 million fibroblasts per ml. These fibroblasts are then put into an injectable medium, and then we inject those fibroblasts into the deficient papilla. Now, we're not injecting collagen. This isn't a filler. We're injecting living cells that then have the potential not only to maintain the result, but maybe even improve the result over time. And again, the fibroblasts do a lot more than just produce collagen. They're important for cell proliferation, extracellular matrix production, growth factor production, collagen production. So here I have my magic potion here. Again, this isn't collagen. This is a solution of 99.9% pure fibroblasts. And I'm going to inject and plump out this papilla, right? Probably not. This material was used initially to plump out skin lines and smile wrinkles. And you know, you can imagine with your face you could do that. But all of you have injected local anesthetic in papilla. You know you're not going to plump that out. We knew that, of course, so we developed what we term the papilla priming procedure, just a controlled surgical insult so that we end up with swelling. So at 3 days, you see that it's swollen above baseline. At 7 days, it's not quite so acute, but still swollen. By 21 days, all the swelling's gone. Well, how can we leverage this to our advantage? Well, we chose to go in at 7 days, at 5 to 7 days, and inject either with placebo or with 200 million fibroblasts per ml. And I chose 7 days because if you remember back to the wound healing cycle, at about 7 days, you're moving from the inflammatory part of the wound healing cycle to the granulation tissue formation phase. The body says, okay, fibroblasts, we're shutting down, collagen accumulation is waning, you're beginning to move into the wound contraction. So I want to boost that. If the body's shutting down its own fibroblasts, I want to hit it with more, and we did that in 3 doses every 7 days. Now, we measured this in a lot of ways, but the way that was most sensitive was through digital photographs. On the y-axis, this is open interproximal space. So on the top of the y-axis is an open interproximal space, on the bottom is closed, and these are just time points. So this is the papilla primings, okay? So we do our little surgery, and this is swelling, okay? So it's closing down just from swelling. This is our first injection of fibroblasts, second injection of fibroblasts, third injection of fibroblasts. Now, if we were just injecting a filler, this is all you're going to get, right? But look, even though we didn't inject any more, the open interproximal space closed. How's that possible? It's possible because those fibroblasts are taking up their natural structure in the dermis. They're producing collagen. They're thickening the dermis and maintaining the result over time. I want everybody to look at the center. I'll show you a time lapse of one of our patients. You know, you can do anything with computers, but nothing's altered here. So look at the center here. So we know from this project that we certainly can do this kind of thing. We know that autologous fibroblasts are safe and may be efficacious for the treatment of open and proximal spaces. Our study showed that investigators and subjects' visual analog scale assessment of test sites were superior to placebo. Our objective endpoints failed to demonstrate statistical significance, but further studies are needed with more appropriate power and more sensitive measurement techniques to really look at that. So here is this patient that I'm injecting. At this point, I didn't know whether this was a placebo or it was a cells. After the study's over, I find out these are cells, so you'll see it blanching. We're injecting anywhere from 4 to 6 million fibroblasts per papilla. So here it is at day 0. Here we are at 4 months, clearly improvement. This patient is still in my practice. She was in my office about a month ago on maintenance, and I want you to look at the change we now have at around 5 years. So it continues to improve. These fibroblasts are still doing their job, and again, theoretically, it's possible they can continue to close it down to the limits of the embrasure. So let's move now from the live cell end to the biologically active molecular end of the tissue engineering matrix, and let's spend the rest of the time talking about studies that we've recently done using recombinant PDGF. We published 2 papers last year in the Journal of one in Journal of Periodontology, one in the International Journal of Period and Restorative Dentistry. One paper centered around clinical parameters and the other around histologic parameters, comparing the connective tissue graft to the coronally advanced flap with platelet-derived growth factor and TCP. Dr. Peter Schupak did a fabulous job with the histology, very world-class histology. This is a 30-patient study, 6 months. Primary efficacy parameter was change in recession depth. Secondary, you can see on the screen. And at 6 months, these were the ones that we had statistical significance between. We had change in recession depth, percent root coverage, which again, the same data just expressed in a different way, and pain and discomfort was significant between the 2 procedures as well. The results were that we achieved 91% root coverage with our coronally advanced flap with the PDGF, and we achieved 98% root coverage with the connected tissue. Again, if you look back at systematic reviews, both of these are higher than you would expect. Most systematic reviews are going to suggest that in Miller Class 1 and 2 recession, you're going to achieve around 89% root coverage, and most systematic reviews would tell you if you're using just a coronally advanced flap, that you're going to get about 82% root coverage. So as a clinician, I always want to know what's the added value, what am I paying for? Clearly to me, there's some added value here to placing something under that connective tissue flap. So here is, again, we've marked the CEJ with a pencil, 3 millimeters recession. In this case, we're doing full thickness flap, not partial, because I'm going to try to grow bone over that root surface as well. I've already done my root planing and biomodification. I'm placing the little PDGF on the root surface. We've already hydrated the TCP, and I'm placing that now over the root surface. I just want a little bit of this. Don't put a big blob of this. You just want enough to keep the flap from collapsing down on the root surface so that you have room for regeneration. And we're not placing a cell-occlusive membrane on this. We're placing just a collagen wound dressing. With most biologics, you don't want to use a cell-occlusive membrane, so this is just a collagen membrane that's going to go away very quickly. I'm hydrating it with the PDGF. Now it's hydrated. We advance the flap. And here's what we have at 6 months comparing to what we had initially and comparing to the opposite side with the connected tissue. So a very equivalent result to our connected tissue control. Now, anytime you and I are covering root surfaces, we've got 3 goals that we want to try to achieve. The first is we want to restore the protective functional morphology, okay? Second is we want to create an aesthetic environment. And I think I've shown you that we've been able to achieve both of those goals with the coronally advanced flap with the PDGF and the connected tissue. It is the third goal